Malaria is one of the major causes of death in Africa, especially among young children. Almost all severe and fatal malaria is due to Plasmodium falciparum. This video describes the various kinds of disease that can result from falciparum infection and how they can be recognized. The video is part of a training module on the management of severe malaria. It will not discuss treatment, which is covered in another part of the module. In communities exposed to frequent infections with Plasmodium falciparum, most children develop some degree of immunity to the disease, even though they may still harbor parasites in their blood. Many children in this picture who are not at all sick may be infected with falciparum. Some infected children show no symptoms at all. When a falciparum infection causes illness, this may occur as a fever with nonspecific symptoms such as lack of appetite, vomiting, weakness, mild cough, or diarrhea. In some children, especially those who do not receive prompt treatment, a falciparum infection may progress to severe disease, which may be life-threatening or fatal. A chronic infection may also lead to anemia. This video describes the clinical patterns that constitute severe malaria. In African children, 4 important patterns of illness or clinical syndromes may occur in severe malaria. The 4 syndromes are general body weakness, prostration, severe anemia, distressed breathing, altered consciousness, and/or convulsions. A child may develop just one syndrome or several at the same time. Any one of these syndromes indicates a need for urgent treatment. Other causes may also induce the syndromes that can occur in severe malaria. When you see a patient with fever or with a recent history of fever who also has one of these syndromes, you must consider other possible causes as well as malaria. Let us explain these syndromes in more detail. First, body weakness. Here, there is no disorder involving the other 3 elements, but the child has severe general weakness or prostration and needs to be treated urgently. We say that a child has prostration when it is unable to drink or suck at the breast, or is unable to sit or stand. Second, severe anemia. This child has severe anemia. The palm of the hand is very pale compared to the mother's hand, and the conjunctiva also shows severe pallor. Urgent treatment is needed to save the child's life. This can occur at any age, but is particularly common in infants and very young children. Mothers can best recognize severe anemia by comparing the child's palm with their own, as in this case. Here are other examples of pallor of the palms in children with severe anemia. The conjunctivae of the eyes also appear pale. In this child, there is also some jaundice on the white sclera of the eye. Children can often tolerate severe degrees of anemia without appearing very sick. There are 2 ways to assess the severity of anemia. One is to check the child's condition. Is it very weak? Does it have any difficulty or distress with breathing? Is it lethargic or unconscious? The second is to measure hemoglobin concentration or packed cell volume. This helps in directing treatment, but it is not sufficient in itself, and you need the clinical assessments we have just mentioned. When examining a child with anemia, you may note the size of the spleen, which is usually large in malaria. However, this does not help in assessing the severity of the child's illness. A large spleen is present in almost all children in areas of intense malaria transmission. It is more important in this child to note the deep breathing. Assessing the size of the liver is useful because a rapidly enlarging liver is a sign of possible heart failure. You must note the liver size at your first examination, so that liver enlargement can be recognized if there is an increase later. Third, effects on breathing. Any child with fever may breathe rapidly. When you assess a child's breathing, you should try to answer 3 questions. How fast is the child breathing? Is there indrawing of the chest wall? And is the breathing deep or shallow? The sign that best indicates severe respiratory distress is indrawing of the chest wall. As this child breathes, the lower part of the chest wall is drawn inwards. This is an important sign. If a child has respiratory distress, look particularly for deep breathing. This suggests acidosis, the commonest cause of respiratory distress in severe malaria. In the breathless child, look carefully for evidence of pneumonia. Occasionally, an anemic child may have heart failure, suggested by an enlarged liver, raised venous pressure, crackles in the chest, and a galloping heart rhythm. You may also note flaring of the nostrils. This is common, but it is not a useful way to assess the severity of respiratory distress. Another sign commonly noted is intercostal recession, as in this child. This too is unhelpful in assessing severity. Fourth, syndromes affecting the brain. These children have become unconscious after a short fever illness. We have seen that malaria may affect a child's brain in different ways. There may be drowsiness or lethargy, often accompanying severe body weakness. There may be unconsciousness or unrousable coma, as in the children we have just seen. Or there may be convulsions. In this child, who has unrousable coma, the arms and legs are rigid, and the arms are held in a flexed position. This is known as decorticate rigidity. Children with malarial coma may adopt other positions. For example, arching of the back, or opisthotonus. Arching with rigid extension of arms. This is decerebrate rigidity. Sustained postures of limbs, or posturing. In this child, note the sustained elevation of the left arm and of the eyes to the right. Here too, the child holds one arm up in a flexed position. Convulsions, seizures, are common when malaria affects the brain. In a young child with high fever, a convulsion may simply be due to high fever, a febrile convulsion that lasts a few minutes. The child usually regains consciousness within half an hour or less. When not simply due to fever, convulsions in malaria may be single or repeated. They may be simple convulsions of the tonic-clonic type or more complex. They may affect one part of the body or several. Sometimes there may be almost no visible movement. This child has generalized clonic movements that persist for several minutes. The movements involve both arms, shoulders, and legs, and also the head. Note also the twitching of the left eye. This child has a prolonged generalized seizure. In another child, there is repetitive movement of the head and also of the lower part of the body. It is clear that this child, too, has a prolonged seizure. The left side of the mouth and the left eye are also twitching. This is the same child. The head movements have now stopped, but local twitching movements of the left side of the mouth and the left eye are continuing. He is now having focal seizures. Note that the eyes are continuously looking to the right, although the child is unconscious. The child has a repetitive movement of the left leg. Any purposeless, frequently repeated movement should suggest the presence of convulsion. This child also has hypertonicity of the arms and especially of the right hand. Although the hand is not twitching, the repetitive leg movement we saw earlier suggests that the rigidity in the hand is due to seizure. Note the incontinence of urine that commonly accompanies a convulsion. This child also displays a recurrent grasping movement of the left hand. Again, a repetitive movement like this in an unconscious child is likely to be due to seizure. The repeated and inappropriate cry in this child is also due to convulsion. Here is another child whose convulsion is causing a repeated cry. The associated twitching of the left hand indicates that this child is actually convulsing. Note that the child's eyes are constantly deviated to the left. This is part of the process of the seizure. Sometimes you may need to look very carefully to see any movement at all as a clue to the fact that a convulsion is occurring. This child has very slight repetitive movements of the face and mouth, and this is the only clue to a seizure. In this child, you can see a slight flickering of the eyebrows, which is all that can be seen of the seizure activity. Both these children benefited from treatment for their convulsions. Convulsions may cause frothing at the mouth, as in this child. We will now review the assessment of the child with severe malaria. Remember that in an endemic area, the presence of parasites in the blood does not prove that malaria is the cause of the child's illness. The history and physical assessment are important in deciding on both diagnosis and management. The history for a very sick child is usually obtained from the mother or guardian. Make sure that the history enables you to determine the following things. Has the child received any treatment for this illness, either from a traditional healer or from the health services? How long has the child been ill, and especially how long has the child been unable to drink? Have there been convulsions? If yes, how many? And has the child had convulsions before? Has the child been unconscious? If yes, for how long? Also assess whether the child is likely to need extra fluids, whether there has been vomiting or diarrhea or fever, which also increases fluid loss. The examination should also establish the possible diagnosis and assess what complications are present and what emergency treatment is needed. In measuring the pulse rate, test also for the presence of dehydration or for a cold, clammy skin. Check the temperature and and the blood pressure. A low blood pressure indicates an urgent need for fluid replacement. The blood pressure may be normal even if the child is dehydrated. Assess the breathing. Look for the rate and depth of breathing and whether there is indrawing of the chest wall. Look for pallor and jaundice. Assess the size of the spleen and especially of the liver. Ophthalmoscopy can provide information on the presence of papilledema, a contraindication to lumbar puncture, and other signs. If the child is unconscious, turn its head to check for uncoordinated eye movement, doll's eyes, a sign of deep coma. It is very important to look for evidence of convulsions and to note what part of the body is involved and how long the convulsion continues. In an unconscious child, it is helpful to measure the level of coma using a coma score. In the Blantyre coma score, a painful stimulus is applied, first by pinching the child's finger. This child does not withdraw his arm when the finger is pinched. Then a painful stimulus is applied to the sternum and to the bone above the eye. This child does not use his hand to remove the pain. Now the child is improving and quickly withdraws his hand from the painful pinch. The child is able to localize the painful stimulus on the chest and push it away. This child does not pull her arm away from the pain, but she cries briefly. The coma score is discussed in the Learner's Guide on Management of Malaria, part of the management module. This child's mother complained that it had passed blood in the urine. The urine was very dark, but microscopy showed no red blood cells. The dipstick was positive for blood. This is known as hemoglobinuria and is due to severe breakdown of red blood cells with hemoglobin in the urine and in the plasma on the right. It develops only occasionally in children with severe malaria and usually responds quickly to treatment. A finger prick blood sample can provide useful immediate information about a child's illness. Measurement of the packed cell volume, or hematocrit, will help in the assessment of anemia. Alternatively, use a simple method of measuring hemoglobin concentration. Blood films allow us to examine for malaria parasites. The thick film allows us to estimate quickly and roughly the presence and density of parasites in the blood. The thin film is useful for counting parasites when there is heavy parasitemia. It is helpful to perform microscopy immediately so that the diagnosis of malaria can be made quickly. In the absence of microscopy, a child with a suspect fever must be treated for possible malaria. If possible, use the same blood sample to check the blood glucose. A drop of blood is placed on the yellow part of the stick, and the result is read within a minute.
Okay.
This child is hypoglycemic and needs urgent treatment with glucose. Hypoglycemia is common in children with coma or convulsions. If the blood glucose cannot be measured, glucose should be given. If a child has fever and coma or convulsions, meningitis is a possibility, even if there are malaria parasites in the blood. Some doctors prefer not to do a lumbar puncture in the unconscious child. If a lumbar puncture is not done, you must treat for the possibility of bacterial meningitis in addition to malaria. When a child with severe malaria has received treatment and is improving, you can assess the completeness of recovery. This child is able to sit up without help and to take a cup and drink. This boy is still quite weak, but he is able to take the pencil, to pass it from one hand to the other, and eventually to give it back. He can repeat the words the nurse says to him. This girl is being assessed for walking. She is also having a test of vision and of coordination. She is accurately seeing the small objects and correctly placing them in the container. And she can do this with either hand. This is a good test to see how well the child recovers dexterity, although it cannot be used for very young children. Most children who survive a coma due to malaria make a full recovery, but sometimes there is brain damage, as in this child who is uncoordinated and cannot walk or feed himself. This is another child who is left with weakness of the right arm and leg. When he walks, he tends to fall to the right, and he can hold the pen with his left hand, but not his right. These kinds of residual brain damage tend to improve over a period of months or years, but some children are left with more permanent impairments. Thank you for viewing this video. We hope it will help you achieve better identification of severe malaria in order to give these children a better chance of a complete recovery.